Take a look here and see whether or not the ball crossed the plane before the knees down. No. It was not contact. It wasn't contact, but yeah. Looks like he did cross the goal line. He is not done. He's not giving himself up. I see it as a stumble. So until he does,
Good morning, Dharani.
Sir, good morning, sir.
Takes it in. 13th rushing touchdown of the season. A good start for next team.
Before you use AI to transform business, accelerate growth, predict trends.
Good morning also to Ashik and Govindan and Kareem.
Good morning, sir.
So you can scale it responsibly. Let's create AI that begins with trust with Watson X companies. IBM. Let's create it.
He can also back 500 of the man. Your melty wishes are our command. With the new sugar Swiss and warm your hands and right in your game. Happy day. Happy your way.
No fees or minimums, no overdraft fees, and another reason banking with Capital One is in.
Good morning, sir.
Good morning.
Can I start the presentation, sir? Can I start the presentation, sir?
Good morning, Shyam.
Yeah, carry on.
Morning, sir.
Carry on, Dhanik. Morning all.
So, today's topic is about cuff repair techniques, sir. Just a minute. Sir, our primary goal of cuff repair will be restoration of anatomy, restoration of biomechanics, and the fixation should be strong to resist all the cyclic loading. It should promote healing by increasing the biology. The repair should be tensionless, and also finally it should improve the shoulder function. So tear pattern recognition is more critical because it facilitates the anatomic restoration. It optimizes the tendon biology. It individualizes the repair and reduces the failure rate, thereby improving the outcome. So the classification goes by A to C. A is any fracture in the greater tuberosity. B is full thickness tendon lesion. C is musculotendinous junction lesion, and D is muscle insufficiency. Under B, it is classified into B1 avulsion of tendinous attachment. B2 is medial tendinous disruption. B3 is forcefully flop tear. B4 is bony adhesions. In B1, that is avulsion of tendinous attachment, it constitutes about 90% of all surgically treated cuff lesions. It is further classified based on the size and tendon involvement by Collin in 2014. That is, it depends upon the pattern of involvement of tendon, that is supraspinatus, infraspinatus, superior subscapularis, and inferior subscapularis. Depending upon the tendon retraction, it was classified by Patty in 1990. If the proximal stump is near the footprint, it is type A. If the proximal stump is near the humeral head, it is type B. If it is near the glenoid, it is type C. And depending upon the tear pattern, it was classified by Burkhardt, which we are going to see in further slides. In B2, that is medial tendinous disruption. It can be primary, that is chronic or acute. In type A, the tear would be near the footprint. In type B, the tear would be at the musculotendinous junction. So depending upon the Davidson and Burkett's classification, the tear pattern is classified into crescent type, longitudinal, massive contracted, or cuff tear arthropathy. Based on MRI, it can be classified depending upon the tear length and width. That is, tear length can be measured in coronal images between the proximal and medial stump. And in case of absent lateral stump, it can be GT can be taken as a reference point. In sagittal image, the width is calculated from the anterior and posterior stump. In absence of the anterior stump, coracoid can be taken as a reference. In crescentic tear, it constitutes about more than 40% of cases. That is, it is a direct detachment from the tendon from the footprint. That is, it may involve mainly infraspinatus. Here, the length will be less than the width. That is, length will be less than 2 centimeters. In case of longitudinal, that is U-shaped tear, it is less common. Here, the medial extension of the proximal stump is more, because of which the mobility of the stump will be poor. That is, here length will be more than the width, and width will be more than the less than the 2 centimeter. In case of L-shaped tear, that is constitute about 30% of the tear. It is similar to U-shaped tear, but here only one margin will have greater mobility. In case of L-shaped tear, posterior stump will be having the more mobility in here, in which we have to mobilize the apex region to reduce to the side-to-side repair. In case of reverse L type, here anterior leaf will be more mobile, for which we have to pull the anterior leaf to the proximal posterior stump, thereby repairing the side-to-side. Here, L-shaped here, the anchor placement is important, where it should be placed at the posterior lateral corner of the footprint. That is, bringing the apex to the posterior lateral aspect. and sutures are also passed to the posterior lateral portion of the torn cuff that will be approximating the tear pattern. So coming to B3, it is a Fosbury flop tear. Here, the full thickness tear that has flipped upon itself and adhered medially. It can be identified by MRI with 5 characteristic, that is thickened tendon if more than 9 millimeter. We can visualize the tendon stump with supromedial orientation and also fluid accumulation in the subacromial bursa, abnormal orientation of the fibers in T1 images, and there will be adherence between the bursal slide and the wall of the subacromial bursa. So coming to the goal of the primary cuff repair is tensionless repair. So we have to bring up the mobilization of the cuff. That is, it can be carried out by 4 steps. That is bursectomy, spine, releasing the spine of scapula, scapular release, or coracoid release. First is bursectomy. We have to do subacromial bursectomy to visualize the cuff using radioablation or shaver. Then we have to release the spine of the scapula, that is supraspinatus, anteriorly and infraspinatus posteriorly. And we should not go more medially more than 1 centimeter because there runs a risk of injuring the suprascapular nerve. And next is the intra-articular release, that is capsular release. It should be done from posterior capsular release to the superior glenoid. And in the same way, in the superior glenoid, we should not go beyond the 1.5 centimeter from the superior glenoid. There lies the supraglenoid noise that runs the risk of injuring the suprascapular nerve. And finally, coracoid release. Here, coracohumeral ligament should be released, thereby releasing the anterior spinatus from the adhesion. So finally, anterior interval release can be done. That is done between the plane of subscapularis, that is a rotated interval, and the supraspinatus. It should be done from the root of the biceps to the coracoid. And the second is posterior interval release, is runs between the plane of supraspinatus and the infraspinatus. So posterior interval release should be avoided because it has a poor results because of the decreased revascularization. So many papers have found that the interval release, especially posterior interval slides, or runs a risk of devascularization. So it should be avoided at the max. So in case of small tear, coracohumeral ligament should be released from the base of the coracoid. If it is medium tear, it should be add on with subacromial and subdeltoid bursectomy. And if it is a medium tear with cleavage, then we should be add-oning with capsular tissue beneath the cuff. And if it is larger tear, then we have to add on with entire subtendon capsule and also plexus of veins and bursa. If the large tear with superior migration, then we have to do 360 degree of capsular release and should be add on with anterior and posterior interval release. Burkett in 1996 invented that marginal convergence. That is, in case of L or reverse L tear shape or U shape, we have to approximate the anterior and posterior stump and side-to-side suturing to be done, thereby bringing the medial stump can be to the footprint laterally. So by doing this, it reduces the tension and also tendon to tendon repair can be possible, and it reduces the gap. In case of L-shaped tear, apex reduction can be easily done, and also it brings about the tensionless repair. So in case of medialization of the footprint, it was found that 3 to 10 mm of medial advancement of the tendon brings about the negligible impact on the moment arm. That is, if it is the medialization is more than 10 millimeter, then it limits the range of movement. So less than 10 millimeter is a viable option. The next step will be the greater tuberosity preparation by decortication. It improves the vascularity. There comes a term called crimson duet. It is a reddish bed type of configuration where we have to make a bony vents the footprint. The deep should be less than 5 millimeter, and it should be spaced between 3 to 5 millimeter. So it was found that it increases the healing rates in large tears, and also it significantly improves the tendon integrity at insertion. So anchor insertion should be should be made at the dead man's angle of not more than 45 degree. And at the time of anchor insertion, the arm should be adducted and also slightly rotated so that the direction of the anchor will be ideal, and also it will be more closer to the cartilage margin. So coming to the cuff repair tension, if the tension is higher, then it results in poor subjective and objective outcomes. And also, if the tension is higher, it is associated with the higher retear rate. So where should we place the single row is that if the anchor is placed more lateral, then there is a 5 times increase in tension. So it should be avoided. So steps in single row repair is that first triple loaded anchor or double loaded anchor should be placed. Then we have to place the anchor as medially near the cartilage. And placement of the anchor should be at the dead man's angle, and we have to bury the anchor up to 2 millimeter beneath the cortex. And the eyelet of the suture anchor should be facing the cuff, and bice should be just medial to the rotator cable, where the integrity of the tendon is higher. And the stitch should be simple, and it should have also loop and a good knot security. And that bony bend should be made deep to the bone, and also it should be directing towards the humeral shaft and not towards the humeral head. So single row suture technique, it lowers the stress per suture, and also is resist the gap formation better. There will be increased construct strength. In case of many studies told that in single row, triple loaded ankles are functions better. And in case of 2 centimeter to 4 centimeter tears, single row holds good. And in 2 years of follow-up, 91% of intact in for follow-up MRI, and also has good patient-related outcome measures. So single row cuff repair mainly in type 2, that is near the bone tendon junction, whereas type 1 is the more common in single row repair, whereas in type 2 it is musculotendinous junction. So coming to the double row repair, it is found that it is more anatomic, and many studies prove that double row has better footprint restoration from 2007 to 2020. Because the contact area in single row is during abduction, it is minimalized, whereas in case of double row stitches, the contact area and footprint is more integrated. So many types of suture can be done in case of a double row repair technique. Conventional double row, trans-osseous equivalent, that is speed bridge, or tension band repair can be done. So steps in double row repair. First, we have to identify the tear pattern as was discussed. Then we have to decorticate the greater tuberosity. Then we have to release the cuff, as like in single row. Then medial row preparation to be done along with the crimson divide bony bends. Then doubly loaded suture anchor is placed. Then either mattress simple suture is taken over the cuff. Then notch tied should be loose because it decreases the integrity of the tendon. Then lateral row anchor should be placed at the greater tuberosity. Then double repair should be complete. As a small technical note, in the medial row should be as close to the cartilage, and the mattress suture over the tendon is acting as a bridge and using a retrograde suture passer. In case of lateral row, it should be done at the greater tuberosity and footprint. That is using the antegrade suture passer, and the bite should be at the lateral end of the tendon. Here, the medial row is fixed prior to the lateral row. So advantages of a double row suture bridge technique is it increases the contact area, and because of the increased contact area, it dissipates the force that's acting over the tendon to a greater area. It increases the number of points of fixation and also increases the strength of initial repair construct. It increases the load each suture loop and knot, and decreases the load each anchor. Disadvantages are it is over tension and tension mismatch of the repair. The potential for devascularization and interference with the healing, and also it has bulkiness of repair and mechanical irritation in the subacromial space. It also involves technical difficulties, and it's a bit expensive. Many studies shows that the repair technique did not affect the final functional outcome. Coming to trans-osseous repair, here first we have to, as like medial row, we have to make a medial tunnel. Then using a ortho tunneler, first the one end is held at the medial tunnel, the other end at the GT, thereby making a lateral tunnel. And passing a suture passer using ortho tunneler, the suture passer is passed to the lateral tunnel and brought out to the through the medial tunnel. Then with the suture passer, we have to pass at least 3 sutures through the tunnel. Then we have to tie it. But the study by Burkhardt told that the in case of anchor, the tendon failure can happen, but in case of tunnel, bony failure is subject to happen. So in order to avoid it, the rotator cuff should be repaired without tension, and also the trans-osseous bone tunnel should extend distal to the weak metaphyseal bone into the cortical bone for greater fixation strength. And also it was suggested that the plane of medial tunnel and the lateral tunnel should be in different plane. The study shows that the anchor group failed at an average of 309 Newton, whereas in bone tunnel group fails at an average of 339 Newton in case of a trans-osseous repair. So another technique of a speed-based trans-osseous equivalent is also here. You could see a small video demonstration. First, we have to apply the medial row suture. And instead of suture, we have to use a fiber tape. And once it is a medial row is done, it is taken to the lateral portal. Again, it will be bite is taken in the tendon at the rotator cable. Medial row is completed. And followed by reduction and lateral row placement. Here, it is a knotless fixation. It decreases stress in the tendon. And another posterior row also is taken and taken in the posterior double row. So in this technique, in speed-based technique, it improves the stability and strength of the construct at the underside of the rotator cuff repair. And the fiber tape knot slides are more easily through the cannula without worry of entanglement of compared to the suture. Whereas in case of fiber tape, it is biomechanically stronger than the suture. Fiber tape disadvantage is that the fiber tape does not slide as well as the suture in the eyelet of the anchor. So in case of trans-osseous equivalent repair, it improves the pressurized contact area and mean footprint pressure, which enhances the healing. It brings a medial mattress knot flush with the tendon, which avoids the edge instability against the coracocampal ligament arch. So it does not rely on the lateralmost aspect of the torn cuff, whereas it relies on the medial tendon muscular tissue. Trans-osseous equivalent repair is interconnected and load sharing. Message. For a cuff repair, the clinical evaluation and the rehabilitation and individualized treatment should be mandated. The ideal cuff repair should contain high initial fixation strength. It should be tension free, and the gap should be minimal, and it should maintain the stability till the healing. Thank you.
Thank you, Dharani Kumar. You have explained very well the concepts of rotator cuff repair and which kind of rotator cuff repair is prone for failures and all has to be mentioned little bit more. History-wise, it is elderly patients more than 70 years and cuff tear duration more than 6 months. And a degenerative cuff has got more higher chances of failure compared to an traumatic cuff tear. Even a traumatic cuff tear for a duration of 6 months has got a good prognosis, but a degenerative tear is one which has lost its vascularity as well as the cuff tissue quality. So those are the ones which has to be kept in mind when you're subjecting the patient for investigation. Now, investigation-wise, the presence of fatty infiltration, as I told you, is very, very important. That will decide whether a cuff is repairable or not. And if at all it is repaired, does it get back its nutrition and function as a normal cuff? So those are the things which needs to be assessed. As far as the presence of massive cuff tears, which is involvement of more than 2 tendons, that is supraspinatus and infraspinatus, keep in mind the infraspinatus is a very essential component because the footprint of supraspinatus is very small, and the reducibility of the infraspinatus is what determines the repairability of the cuff. So we have to make all the efforts that are possible to release the tissue both on the underside as well as on the subacromial side without compromising its vascularity and get back the reduction as much as possible. Now, the few methods which have been discussed previously by Steve Burkhardt is the interval slide, then the release from the clinoid and the release from the subacromion, and sometimes associated with the suprascapular nerve release also. These have been quite successful in initially fixing the cuff onto the footprint, which means you can bring them back onto the footprint, or even you can medialize the footprint not more than 10 millimeters and fix it on. But does it heal? That is a question. The healing always depends upon not the, of course, it depends upon the accuracy of the cuff repair, but the bone bed should be vascular. That is more important. If the bone bed is sclerotic, which is commonly seen in case of degenerative cuff tears or chronic cuff tears, then you are going to stick a tissue onto a bone which does not provide any mesenchymal stem cells for good healing. So always most crucial element of cuff repair, in addition to good reduction, tension-free fixation, is a bleeding bone surface, which you have mentioned as a crimson duvet. That has to be done carefully in cases with osteoporotic bones. Normal bones, you can do a crimson duvet. In osteoporotic bones, the irregular ridges which are seen on the GT has to be just burred superficially. You have to use a burr and make sure that the sclerotic bone is removed alone. And that will ensure the cuff is placed onto a healing surface. Another most important factor which would have been stressed upon is the delaminated text. Now, if a full thickness massive cuff tear, even if it is chronic, but it is single layer, then it's a good sign. It's a good prognosticating sign. If it is delaminated, then it's a bad sign. Now, you know, as per the histological picture, the supraspinatus and the infra has got 5 layers. Layer 1, 2, 3 is one and is the superficial layers, and layer number 4 and 5 are the deep layers. And usually any partial cuff tear happens between layer 3 and layer 4. What happens as the age progresses, and if the tear is persistent for more than 6 months, this layer 1, 2, and 3 becomes insufficient. It loses its vascularity and it becomes extremely thin. To explain clearly, the layer 1, 2, and 3 becomes like a wet toilet tissue paper. So even if you try to take a bite through the this tissue, when you're trying to tie the knot, the fiber wire stitch just passes through or tears through this layer, and it is absolutely of no use in repairing that tissue. And if I remember in the previous case last week when we operated reverse shoulder arthroplasty with intact supraspinatus tendon, we were able to just peel the tendon with the forceps alone. It was attached to the GT, but we were able to peel it with the forceps. So that is a quality of a tissue in a 71-year-old male patient. So you have to be very cautious. The most important layer is layer 4 and 5, which is a thick, and it is considered to be the articular-sided layer, which has to have a firm attachment onto the medial margin of the footprint, that is in the juxta-articular area. If that tissue is brought back tension-free and repaired well, then this layer 1, 2, and 3 can easily sit onto this layer and aid in healing. If that is not done, then if you try to repair only the layer 1, 2, and 3, then the chance of failure is very high. That is the reason for most of the massive cuff repairs failing, because you have to identify. So the outcomes of the cuff repair depends upon the delamination also. If the delamination is present and it's quite severe, then the prognosis is very bad. Coming to the type of repair, the type of repair is very, very important as far as a small cuff. If it is a very small cuff, if the anterior and the posterior cable of the cuff is intact, a single row repair is good enough. Now, the experts say you have to maximize the footprint contact area. That can be definitely achieved with a single row also, not just a single row simple stitch configuration. You have various configurations like the single row parachute technique, the single row Sukhoi technique, then the single row cross bridge technique, which was explained by Dr. Raju Ishwaran from Delhi, which mimics a trans-osseous equivalent. So there are many techniques which are available, can be reproducible also. So if it is a small tear, don't worry about the repair configuration. All you need is to bring back the cuff onto a bleeding bone surface, and adequate immobilization will heal well. The massive retracted tears are the ones which needs a good contact surface, and for which a double row is definitely needed. Now, if we compare the outcomes of double row with a trans-osseous cuff tear, it will not be a good comparison, because it is obviously understood that trans-osseous cuff repair is the best, and nothing can replace or mimic the biomechanics. The advantage of doing a trans-osseous cuff repair is, one, you are just making it as a load bearing device. Now, load sharing, when you use a suture anchor, the load of the cuff is shared. So the chances of this load sharing device to fail, that is pulled out of the bone, is very high. When it becomes a load bearing configuration like a trans-osseous cuff repair, then the chances is very, very low, unless and until the patient has an osteoporotic bone. In the in the presence of an osteoporotic bone, the experts have come out with, instead of using the fiber wire, you can use a fiber tape, which will have a less chance of cutout through the bone, and it's as good as a normal cuff status. Another most important advantage of this trans-osseous cuff repair is, in case if it fails, okay, the only way it can actually fail is either it can cut through the tendon or it can cut through the bone. Cutting through the tendon is the most common in case of a degenerative cuff tears. We still have one more option of repairing it, because the bone quality will be intact. Whereas in an anchor cuff repair, you don't have bone substance, and you have previous existing anchors, and your repair is becomes difficult. Third most important factor with the trans-osseous cuff repair, with which the experts like Brett Sanders are saying, is the post-operative rehabilitation pain, which is associated with trans-osseous cuff repair, is much better compared to those with suture repairs. If you remember, in the WhatsApp group, I have shown one cadaveric study where there are multiple number of anchors. 5 anchors have been put on the bone on the small GT, which occupies the entire space in the GT. So this occupies space. This is like a space occupying lesion, and acts as a pressure symptom, and it will produce pain for patients with these kind of cuff repairs, and the rehabilitation becomes difficult. And rightly, we are seeing our patients, we are having the subsets, those with anchor repairs, those without anchor, with trans-osseous repairs. Those who have undergone trans-osseous cuff repairs are able to rehabilitate better, and their post-operative pain score improves pretty quick. So this is a very important factor that needs to be considered. And I personally believe trans-osseous cuff repair has not been replaced by any other technique so far, and it holds good and as best as possible. So if you know the technique and which configuration to use for what type of cuff repairs, then you can probably choose the best one for that particular patient. Keep in mind, to understand the anatomy and orientation of the cuff and its insertion site, always start your career with mini open cuff repairs. Don't go directly arthroscopic, because there is always disorientation which is associated with your initial practice. Open the cuff, look at the cuff orientation, see how it goes and inserts, then try to use various other configurations, open, get the confidence, and then go arthroscopically. That would be the best option to address any cuff tears in your future practice.
Morning, sir. Am I audible and screen visible, sir?
Yes, Praveen.
So, morning, everyone. I was talking about mini open cuff repair today. So the natural question which we have with with the advent and numerous studies supporting arthroscopic repair and multiple stitch configuration is, do we really need open cuff repairs today? Uh, so this is an article which came across published in IJO, which is trying to address the exact question. So so they reviewed all the recent literature comparing arthroscopic versus mini open as well as mini open cuff repairs of the recent past. So this is a general trend they found. So there's a general linear increase in use of arthroscopic cuff repairs all over the world, and there's a general declining trend with the use of open cuff repairs with open as well as mini open cuff repairs with for mini open technique for cuff repairs. So these are the studies that they included in this review. So as you can see, they have they had good volume studies, had a good cohort of patients with both in open repair as well as the arthroscopic cuff repair group. So as you can see in this study, there are about 1,000 patients with open compared against nearly 500 patients of arthroscopic and 900 patients of mini open repairs. But most interestingly, they found with respect to the post-op parameters, post-op rehab, post-op pain, they didn't find much difference with the arthroscopic repairs as compared to mini open repairs. So these are the key results put forward in this study. So naturally, when comparing the surgical time in mini open was about 78 minutes and arthroscopy was 19 minutes. So surgical time, as you'd expect, was faster in open procedures as compared to arthroscopic procedures. And however, the rehab times are similar in both conditions, mini open as well as arthroscopic procedures, not open procedures as such. And the post-op pain is also interesting. They found was only similar between mini open and arthroscopic procedures with the current analgesic protocol used world over. However, complication rates wise, there are definitely higher complication rates in open cuff. This again was more complications were attributed when they including the open cuff group and not the mini open cuff group. Again, this was although a biased finding in the sense most of the authors resorted to mini open or open cuff repair when preoperatively they thought that it might be a massive refractive tear which they may not be able to address arthroscopically or in a older individual with a more degenerative tear. So the complication probably might be attributable to age and other confounding factors rather than the technique alone. Most important complications they came across when using mini open technique or open technique was stiffness, infection, and more importantly, deltoid dysfunction. And the infection rates are also naturally higher in open techniques as compared to arthroscopic patients. Again, this was also confounded by the fact that most surgeons resorted to open procedures when they felt an obese patient arthroscopically addressing a massive tear might be difficult. So this is again a slightly biased finding. However, the retear rates with the mini open repairs and the open arthroscopic procedures are fairly similar. Moving on to other factors, economic consideration. Naturally, this table depicts the average cost of an arthroscopic procedure, just the consumables cost of arthroscopic procedure in the UK for an arthroscopic procedure against an open procedure. As you can see, the cost of an arthroscopic procedure is nearly 4 times more than an open procedure. And with respect to learning curve, so as you'd expect, the time duration for surgery was less with an open procedure as compared to arthroscopic procedure. But interestingly, they found both actually follow a similar gradual learning curve. In the sense, there was a steep decrease and then a follow like a similar course of plateau in both procedures. However, another point to note is that there is a number of cases which they determined where after which the trainee becomes very proficient in the procedure. So, which was only 17 cases open repairs as opposed to 35 in case compared with the arthroscopic repair. So, in other words, you need experience on half the case arthroscopy to be very familiar with the procedure, with an open procedure as compared to arthroscopy. With regards to clinical outcomes, the clinical outcomes again with this meta-analysis also they found were similar in all intervals, even at the early post-op period. So, meaning to say, mini open cuff repairs had similar functional outcomes to arthroscopic procedures even at 6 months follow-up. So, based on this, the authors concluded that an arthroscopic procedure can be preferred for a small to medium-sized tear, and in cases where a suspected intra-articular pathologies or a partial thickness tear. And the choice of open surgery should be made in case of a large and massive tears, there is a complete subscapular tear, which might be difficult to address with arthroscopically. And when expecting poor tissue quality and extensive delamination, and also in case of revision surgeries where arthroscopy has already failed. So to conclude, they said that the arthroscopic procedures may not always be possible due to multiple factors, either because of the morphology of the tear, lack of skill set on the surgeon side, or other logistical reasons, lack of arthroscopic equipment availability. Hence, we as shoulder surgeons, they advocate that it's important shoulder surgeons be familiar with both open as well as arthroscopic techniques and apply the right technique at the right place. So it's about what we mean when we talk about open cuff repair. The first cuff repair was introduced in 1911 by Codman. However, it was further modified by Neer in 1972, and these are the fundamentals he has listed down to be followed when doing open cuff repair. So back then, when open cuff repair was done, the deltoid was stripped and it was reattached. So the deltoid should be meticulously repaired to regain its functionality. And as with any cuff repair, adequate subacromial decompression is mandatory. Once the subacromial decompression is done, the cuff tendon should be released from its surrounding adhesions and mobilized to the cuff footprint. Secure trans-osseous fixation is necessary for post-op rehab. And early passive ROM can be allowed. Only passive ROM can be allowed when doing an open procedure, and the supervised rehab is mandatory. So even with the presence of available scopy, surgeons do prefer open repairs in case of large and massive tears. As discussed, general indications include cases where we suspect poor tissue quality, significant retraction, and significant adhesions, which might be difficult to address arthroscopically. So when doing open cuff repair, a B chair procedure is preferred with the patient placed 60 degrees horizontal. So quickly about the open cuff repair technique. So the necessary landmarks, as you know, is the clavicle, the anterior, anterolateral, and the posterior margins of acromion, and the coracoid process. So these landmarks and 3 to 6 centimeter incision placed over the anterosuperior aspect of the shoulder in line with the language line. Subacute dissection is done, exposing the deltoid fibers. So this will expose the anterior and anterolateral fibers of deltoid. So the deltoid fibers should be stripped off as a whole from the attachment onto the anterior border of the acromion, starting from the AC joint to the anterior border of acromion. And laterally, the deltoid split along its fibers up to 3 to 5 centimeters. Care should be taken not to extend further to protect the acromion. And again, while dissecting, healthy cup of deltoid fascia should be maintained, which is imperative to repair it post the procedure. And as discussed before, subacromial decompression and buccal dissection is done. The tendon is identified, the adhesions are released, and the tendon is mobilized such that it sits onto the footprint. The footprint is prepared using a curette or a bar. And when using an open technique in the initial description, the trans-osseous technique is preferred, where as this is a medial row is placed and the lateral lateral drill hole is placed on the infralateral cortex of the femur of the GT, and with about 1.5 centimeters of bone bridge. Depending on the quality of tissue, simple sutures may be indicated, or modified footstop stitches can also be incorporated to further strengthen a poor quality tissue. And next step is, as discussed, the deltoid reattachment post repair. The long-term split is sutured non-adjoint sutures, and the acromial ends of the anterior end is sutured with drill holes onto the bone. Again, this to be layer by layer repair of superficial deep layers of the deltoid fascia is needed to avoid dehiscence in the post-op rehab period. Good results have been shown with open cuff repairs. So what are the disadvantages when with open cuff repairs? As with similar to disadvantage of open surgery and with respect to cuff repairs, particularly the anterior deltoid dissection. So in cases when there is a case of deltoid dehiscence or loss of deltoid function leads to say diastatic complication, and there is no reasonable alternative to make up for intra. And since the deltoid is taken down and repaired onto it, no active ROM is advisable for 4 weeks. So strict immobilization for 4 weeks is mandatory. And of course, because of the open surgery, there is increased pain as compared to mini open or arthroscopic cuff repairs. So all the issues, as you can see, are more related to the deltoid takedown and the reattachment. So to circumvent this disadvantages, the mini open cuff repairs is thought of. So there are again multiple techniques of mini open described. These are the common techniques I came across. So first is the lateral portal extension technique, where the arthroscopic lateral portal is extended down below to just aid in the suturing of the cuff onto the footprint. And there's a coracoacromial approach, and there's also the anterolateral approach for mini open. Discussing about each technique briefly. So the lateral portal extension is the most commonly used technique for mini open cuff repairs. It was described by Levy in 1994. So this is again in back then it began as an adjunct to arthroscopy. So first steps of the procedure similar to arthroscopic surgery. Arthroscopy was done, bursal dissection and cuff mobilization was done arthroscopically. Once the arthroscopy is done, the lateral portal is extended down below along its line up to about 1 to 2 centimeters. Since most of the cuff mobilization and bursal dissection is done arthroscopically, there is a minimal window needed at the lateral aspect. Minimal dissection, minimal window is needed to attach the footprint. So limited exposure of deltoid is sufficient. Again, this care should be taken to avoid the axillary nerve down below. Most studies showed good results with lateral portal extension technique. So I think with this subacute dissection done, deltoid is split deltoid fascia and the fibers are split along its fibers, exposing a subacromial bursa. So the primary advantage is simpler learning curve, and it has proven results with multiple studies showing good results in long-term outcomes. But main disadvantage is that again, if needed to visualize a large or massive cuff tear, might have to extend the incision much more distally, and this again entails the risk of injury to the axillary nerve. And also, it's a very laterally placed incision. Visualization of posterior cuff will be difficult. This is a disadvantage as compared to arthroscopic procedures. And also another point to be noted regarding how far we can go on the lateral aspect of the deltoid. So this is a study published in UK in 2008, where they did a cadaveric study with deltoid split at varied positions of the arm. They found that in their study, the average distance of the axillary nerve from the acromial distance is from starting at 4.5 centimeters. So their findings, they concluded that 5 centimeter might be going too close to the nerve. So safe distance can be taken as only 4.2 centimeter from lateral end of the acromion. And also the risk was highest when this dissection was carried out in abduction of the arm. So always avoid splitting the deltoid fibers at the arm and abduction. The next technique is an anterolateral technique for anterolateral mini open approach. So this is again similar to the lateral portal extension approach, where the deltoid on approach, where the deltoid insertion is preserved. This is done with a lateral decubitus position with the patient in GA preferably. Similar technique to the lateral extension technique, where the diagnostic scopy is done. Once the diagnoscopy and bursal dissection mobilization is done, just an anterolateral incision is made at the starting from the anterior edge of the acromion. 3 to 4 centimeter incision placed from the anterolateral edge and directly distally. Deep dissection to expose the deltoid fibers, and the deltoid is split between the anterior and the middle thirds along its fibers. When doing this technique, you can also place a suture distally to avoid propagation of the dissection distally, while retraction to avoid injury to the axillary nerve. So as you can see, the deltoid fibers can be retracted using deltoid retractors. And the cuff and the foot, once the footprint is prepared, the cuff can be anchored onto the footprint using sutures. Again, suture configurations depending on the surgeon's preference and the tear morphology. Since this is a very anterior placed incision, the LHP tendon can also be visualized by rotating the arm and can also be addressed. While the resuturing tendon, in addition to suturing the longitudinal split, additional stitch through the bone hole through the acromion also recommended to secure the fixation of deltoid. So the primary advantage of the anterolateral mini open approach is that it allows direct access to the anterior supraspinatus fibers, which is the most common site of tear. And other tears can also be relatively visualized with the rotation of the arm. however, again, difficult to visualize posterior tears. And the other pathology in anti-arthroid arm like the LHB and subscript tears can also be visualized and addressed with this technique. And there is a relatively reduced risk of deltoid avulsions when compared to an open cuff repair techniques. The main complication about most of the open techniques is stiffness. So in general, the stiffness complication rate of stiffness in in open cuff repair is about 11 to 20%. Interesting, in this study with 128 patients, they find come across stiffness about 5.5% in 5.5% of the patients. So yet another described approach, the coracoacromial mini-open approach. This was described in 2016 by Wolfram Thomas, published in Arthroscopy Techniques. The primary advantage again is similar to other mini-open techniques. It's a deltoid on approach, does not detach the deltoids, so allow for faster rehab, and axillary nerve is relatively spared from injury. Surgical technique is similar to the mini-open lateral extension technique. So a patient placed in a beach chair and the arm is held in adduction and internal rotation. As with the other any shoulder surgery, important landmarks is the AC joint and the coracoid process. So with the arm and adduction internal rotation, skin incision is made directly from the tip of antro end of the acromion towards the coracoid process. The skin and soft tissue dissection is done. You can visualize the deltoid fibers. The deltoid fascia is split. Again, once the deltoid is split, care should be taken to split the deltoid fibers only along the line of the fibers. So this might lead to an oblique to perpendicular incision compared to the skin incision line. So once the deltoid fibers are split and the deltoid is retracted, we can visualize the coracoacromial ligament. Again, care should be taken not to extend the deltoid incision too liberally, since this can potentially injure the axillary nerve. The risk is much less compared to the laterally placed incision. So once the CA ligament is visualized, the CA ligament is visualized from its attachment on both ends, and that's dissected from both the attachments, exposing the underlying bursa. The subaqueous bursa is adequately removed and the decompression is done. Acromioplasty can also be done if deemed necessary. Once the CA ligament is removed and the bursa is removed, the cuff can be visualized by taking the arm to different range of movements. Can we use the abduction external rotation to visualize the different parts of the cuff? Again, it's much easier to address the anterior tears of supraspinatus and also subscapularis. Once the cuff tears are visualized, as with other techniques, stone ends are mobilized, fixed onto footprint is prepared and fixed onto the suture and fixed onto the footprint using suture angle. It's a suture configuration of the surgeon's preference. In a severely degenerate tissue should not be included in this repair, since it might compromise the repair rather than aid to healing. And post repair, the stability of the tear can be checked by taking the arm through a range of means. So post repair, once the deltoid retractor is taken out, you can see the fibers falling back into place. So the fibers can be stitched on easily using observable stitches. Then the skin soft is the closing done. So what is the primary advantage of this coracoacromial approach? That it's a simpler operator handling even for a larger test, and easier to perform. Easier to perform for intraoperatively using like a passive ROM control for testing intactness of repair post-operatively. Much direct approach to the cuff, meaning a shorter intervention time, and is also aesthetically satisfying. And there's no retear rates. Retear rates are very minimal or not reported with this technique. Primary disadvantage being there is a theoretical risk of axillary nerve injury, although much less when compared to the lateral extension technique. Tears with retracted and posterior placed tendons with might be challenging. And any bony morphology, any altered bony morphology could again interfere with the surgical exposure and is a related contraindication. So to summarize, this is the when comparing the three different techniques like open cuff repair against mini open against arthroscopic, naturally, open cuff repair does not allow for intra-articular evaluation of which can be done with the mini open and arthroscopic. Since mini open is usually arthroscopic assisted, and the intra-articular evaluation can also be done. The incision size is of mini open is naturally much less than open cuff repair. However, if compared to arthroscopic repairs will be naturally much lesser than the mini open, like about 3 to 4 5 to 7 size incisions. The most important aspect of deltoid surgical incision most is open cuff repair. There's comparatively less with mini open and there's least with the arthroscopic cuff repair. With respect to repair techniques, most describe the use of trans-osseous techniques for open cuff repair. Whereas in mini open and arthroscopic, multiple switch configurations have been described. Early passive range of moves can be allowed in all three techniques. However, early assisted and early active movements cannot be allowed in open cuff repair due to the risk of deltoid dysfunction and deltoid dehiscence, but which can be allowed when using the mini open technique. So, as you can see, the mini open technique also includes incorporated most of the advantages of arthroscopic cuff repair as well. And post-operative pain is naturally least with arthroscopic cuff repair, but that's again debatable. Most studies saying mini open cuff repairs are also having similar pain outcomes as compared to arthroscopic cuff repairs. So, take home message: mini open cuff repair is a very good alternative. We should be familiar with, particularly in cases which are limited by limited resource conditions, with limited like economic constraints from the patient side, or limited experience with the arthroscopic, limited experience on the surgeon side with respect to arthroscopic cuff repair. When doing mini open, always keep in mind to preserve the deltoid and deltoid's functionality. Split the deltoid only in line of its fibers. And while splitting the deltoid, make sure not to extend more than 4.2 centimeters. Since there is there's a higher risk due to the axillary nerve. As opposed to arthroscopic technique, this has a quicker learning curve, and it is generally still preferred by some surgeons for a massive test, which they feel cannot be addressed with. It might be difficult to be addressed with arthroscopic techniques. So as sir just said, to begin with, probably we should start with mini open procedures to be familiar with the cuff mobilization for preparation techniques. Then progress on to arthroscopic assisted, where we try to half most of the steps with arthroscopy and then secure the fixation with the mini open technique, and then move on to full arthroscopic cuff repair. Thank you, sir.
Thanks, Praveen. Thanks, sir. That's a very detailed description about the advantages and disadvantages of mini open cuff repair. It's mini open or open, whatever it is. It's anyway, invariably you're going to open it up. The only difference is whether you're detaching the deltoid or not. Usually, there are some common myths in open cuff repair is the cuff repair actually compromises the deltoid function. Is it true or not? Yes, definitely compromises the deltoid function, but it's just a transient compromise, which means that maybe for initial 2 to 3 months post-op status, the patients will have issues with active assisted range of motion exercise because the deltoid does not fire. But if we respect the deltoid when you're doing the surgical dissection, that can be overcome. And the best way is to go in the anterior raphe, which is between the anterior fibers and the middle fibers. You can go in the interval between that and gently elevate the deltoid, and you can carry out the cuff repair. Exposure is not at all a problem. And as far as the mini open cuff repair is concerned, there is no need to go beyond 4 centimeters below the GT. That is, you don't have to actually expose the axillary nerve, and the incision is that big incision is not at all necessary if you're addressing just the cuff. If you're having associated shaft fractures, yes, you may have to extend and isolate the axillary nerve. Another thing which has been asked by most of the orthopedic surgeons is, can a subscap repair be done using a mini open cuff repair through a lateral deltoid splitting approach? Definitely it is possible. See, when you're doing a reverse shoulder arthroplasty and you're able to expose the subscapularis muscle during the dissection, and it can very well be done for a cuff repair also. The only thing is the arm positioning, the location of your incision, and the type of repair matters. And identifying the subscapular and repairing through a mini open cuff repair is very much a possible scenario. It can be done. Advantage of this deltoid splitting or the mini open cuff repair is, first, it gives you a clear picture of the cuff orientation, and prepares your mind on how to actually address a cuff repair and follow the basic principles of a cuff repair. Because a cuff repair is not from medial to lateral; it is actually from posteromedial to anterolateral extension, as far as the supra and the infraspinatus is concerned. And for the subscapularis, it's infromedial to superolateral. So you need to know the force vectors, and that can be very well appreciated in an open scenario rather than an arthroscopic scenario. Next most important advantage of open cuff repair in current scenario is when you're dealing with an osteoporotic bone. Say, for example, you are approaching an osteoporotic bone for a cuff repair using an arthroscopic technique, and all the anchor pulls out, and you don't have any other option to put the anchor in its proper bone bed. Then you are left with limited space, one, and you don't have any options to fix the anchor onto the bone. And in such cases, you need some bone cements, you need some cemented anchors or vented anchors into which you can apply the cement and fix it. And all this is a time-consuming process with the presence of a saline irrigation which is happening. That becomes a trouble. So in such cases, doing a mini open and securely fixing either an anchor or a bone cement and repairing the cuff is a better option when you're experiencing trouble in osteoporotic bones with suture cut through or anchor cut through. So osteoporotic bones play a very important role in deciding whether you need a mini open or an arthroscopic repair. But pre-operatively, we are not in a position to check which patient has an osteoporotic bone, which patient does not. And that's exactly what we are doing, a CT-based analysis. If at all the GT fractures in case of a very weak bone, at present in our tool, we have something called the specialized GT plates. The plates specifically designed for GT avulsion, which has got holes in its periphery for addressing the cuff tears also. So these GT plates will be like spike plates fixing the GT onto the proximal humerus, and the holes in the plate will help us in repairing the cuff. And this is possible only with a mini open. So mini open cuff repair in our Indian scenario, there are two scenarios where it is very much useful. One is economic constraints. Patient is not affordable but has to undergo a cuff repair, and in such cases, mini open cuff repair is good. And in cases where the bone is extremely osteoporotic, there may be some supplemented fixation needed. And in such cases, yes, mini open cuff repair is good enough. And as you know, the disadvantage is deltoid wasting or deltoid lack of firing in the initial rehab period. But over a period of 6 to 8 months time, you will see that the patient's elevation will be good and the patient's functional outcomes are as good as the arthroscopic cuff repair. But the only hampering factor is pain. The postoperative pain is very severe in patients with open cuff repair, naturally because of the soft tissue dissection. But we have to always try to respect the holy grail of shoulder, which is the deltoid. If you do not respect the deltoid, then whatever cuff repair you do, it's going to be a failure. Any questions? Sir, would you want to add anything, sir?
Nothing, Shyam. It's a good take-home message. Well presented. Carry on.
We can proceed to the spine talk right now. Thank you.
Is Dr. Gopal there? Is he?
Sir, he is available, sir.
Awesome. Gopal, would you like to add a point or two? Okay, carry on. I don't think it's there.
Good morning, sir. Is my screen visible?
Oh, iPad too, yeah.
Yeah, it is visible. Ravi, you can proceed.
Okay, sir. Good morning, sir. Neural monitoring. Neural monitoring is a device used to assess the integrity of the neural pathway intraoperatively. Let me explain about little history regarding neural monitoring. In 1960s, there was increase in the spine surgeries with they noticed that post-operatively, patient used to develop some neurological deficits. In order to prevent that, in 1973, they came up with one test to prevent that neurological deficit, or to assess the neurological status intraoperatively. A test called Stagnara's wake-up test. That is, they'll wake the patient up during surgery by lightening up the anesthesia and ask to mobilize the limb to assess the motor function. But it has some shortcomings, such as patient could become move and change the position, or it can extubate, and it can be stressful for the patient. And also, it is not helpful in patient with have language barrier and it is disabled. So in 1980s, people used physiological modalities to assess the neurological status intraoperatively. It is to assess the integrity of the neural pathway and helps to detect the early detection of neurophysiological changes during the procedure and to prevent the development of new neurological deficit or worsening of pre-existing neurologic conditions. The intraoperative neurophysiology is a teamwork. It consists of a neurophysiology technician and anesthesiologist and a surgeon. This relation allows to rapid communication between the teams and quick resolution of issue and optimize the benefit of intraoperative neural monitoring to the patient. It is done by evaluating the response that are produced by patient's nervous system for various stimulus. Before starting surgery, what we'll record the baseline reading. That is considered as a baseline reading. It's the reference value. If there is any variation from this baseline value, is considered as abnormal. We have to be cautious, and it is monitored throughout the surgery. And the response obtained is recorded in the form of waveforms. The mainly two characteristics of these waveforms are amplitude and latency. Amplitude is just the variation from the baseline to the peak or peak to turf. It is measured in terms of millivolt, and latency, it is from the point of stimulation till the onset of waveform. That is measured in terms of milliseconds. Before starting surgery, the first step is to determine the type of neurophysiological test to be performed on a particular patient who is undergoing surgery. There are various modalities are available, such as spontaneous and evoked. Spontaneous like electroencephalogram and spontaneous EMG, whereas evoked potentials such as somatosensory evoked potential SSEP and motor evoked potential MEP and brain auditory evoked potential VAEP and visual evoked potential VEP and triggered EMG. In spine, we commonly use SSEP, MEP, and EMGs. Let me explain a little. In MEPs, we'll collect the electrodes distally, and the resulting response is collected in the scalp electrodes. Whereas in EMG, the particular muscles have been has been connected and recorded throughout the surgeries. The ideal intraoperative neural monitoring modalities should be user-friendly and highly sensitive and specific to any spinal cord injury. At present, there is no single such modalities exist. SSCP remains the standard despite of optimal sensitivity, suboptimal sensitivity, and myogenic EMPs offers superior sensitivity and specificity. Unfortunately, the technique is not user-friendly as SSCP monitoring. And EMG is very useful and sensitive tool, although it has limited specificity. The sensitivity of SSCP is around 52% and specificity of 100%, whereas MEP is sensitivity of 100% and specificity of 96%. And EMG is sensitivity of 46% and specificity of 73%. Okay, we'll come to SSCP. What is SSCP? SSCP is a somatosensory evoked potential. It monitors the signal from periphery, and the response is recorded in the brain. And the response is recorded in the cortex. For example, in cortical response of lower extremities is recorded in medial parietal cortex, and the potential obtained is called P37. Whereas for upper limb, the potential is called N20, which is located in the primary somatosensory cortex of hand. Okay. In this patient, the scalp electrodes are placed is like for a cortical sensation. It is recorded in CZ and C3 and C4 location using a corkscrew electrode, and this is a fine needle electrode for used for lower extremities and upper extremities. And sometimes when we stimulate distally, we won't get response in the cortex. There are some shortcomings in that. Maybe if electrodes is dislodged, or if stimulus is suboptimal, it can give a false positive results. To avoid that, we use an popliteal force of potential. That means we will assess when posterior tibialis or peroneal nerve stimulated distally, we'll record the reading in popliteal fossa as a popliteal fossa response potential. If popliteal fossa potential is present and cortical response is not present, then we have to think of something is going wrong at the level of spine. Mainly, SSCP is used in corrective surgeries of scoliosis and removal of intraspinal tumor and AV malformations. The main disadvantage is monitoring all sensory transmission throughout the dorsal, only through the dorsal column pathway. They do not provide direct measure of motor function. SSCP are average response. Any response obtained will always be lag behind the real time. And reports of false negative outcome when using SSCP monitoring alone illustrated need of multimodality monitoring. So MEP, motor output potential, it is like when it is stimulated cranially and response is elicited distally. So based on the stimulation, it mainly two types, that is rostral stimulation and transcranial stimulation. In rostral, again, like it can be stimulated epidural using an epidural electrode inserted after laminectomy, or finely placed percutaneous intraspinous needle electrode. And whereas transcranial stimulation, it can be through an magnetic stimulation and electrical stimulation. Transcranial magnetic stimulation, it can be done in an unanesthetized patient, but the machines are expensive, bulky, and tends to overheat, so it is not user friendly. And the resultant response can be recorded at two levels: myogenic level at the level of muscle, at the level of spinal cord. At the level of spinal cord, whenever it is stimulated, the first waveform is formed is called D wave. It could be recorded even when there is myogenic response or not yet formed. This recording response could be recorded even with full muscle relaxant, whereas myogenic response requires either no or very little muscle relaxant. The D waves recorded from epidural or subdural electrodes when stimulated proximally, and it is recorded distally. The first waveform is called D wave, and the subsequent waveform called I wave. It is mainly used in thoracic, upper thoracic and cervical level surgeries, and it corresponds to the initial propagation of action potential within the corticospinal tract. It is hard to record from lower thoracic and lumbar region, where the corticospinal tracts become small and eventually terminates. And D waves could be found irrespective of inhalation agents or neuromuscular blockage. It has its own disadvantages, such as the electrode will be in the field of vision, and it is difficult to lateralize which side is the pathology. Whenever we get variation, but we are not able to differentiate which is the right side or left side is the pathology. It cannot lateralize, that cannot be distinguished. And omission of the lower motor neuron damage and inability to monitor during positioning of the patient, or inability to monitor during the opening and closing of the surgery. And a difficulty of obtaining D waves in those of lower thoracic and lumbar region, and it cannot be used in small children, in general under age of 4 years, because the motor pathway is immature. There are reports in which the spinal cord stimulation MEP monitoring resulted in no significant intraoperative changes despite post-operative neurological monitoring deficits. So they started with transcranial electrical stimulation, which provides more reliable method of monitoring of motor pathways. Beginning of transcranial MEPs monitoring, threshold voltage for each of the body is recorded before starting surgery. The initial current of 100 volt is given, and the response is recorded. And the series of the increase the voltage to know what is the maximum voltage can be given to the patient, and it is recorded. Okay, we'll come to the EMG. It is spontaneous EMG. It's a real-time recording from peripheral musculature and does not require stimulation. And it record continuously from a pre-selected muscle group based on the nerve roots at risk. Spontaneous EMG, whenever there is injury, there will be a single sudden burst of EMG firing will be there. When the nerve roots are compression, a mechanical stress, there will be a continuous repeated EMG firing will be there. When we are approximating the nerve roots, there will be a single spike or burst of will indicate we are near the nerve roots. The electrodes placed in upper limb for C4 nerve root, we place the electrode at supraspinatus muscle. For C5 deltoid and biceps, and C6 at biceps, and C7 triceps and finger extensor, and for C8 finger flexors and T8 hand intrinsic muscles have been electrodes will be placed. For lower limb, for T6 to T12, the rectus abdominis muscle. For L1 iliopsoas, L2 adductor longus, L3 adductor longus and vastus medialis muscles are tagged. For L4, vastus medialis are lateralis tagged. For L5, tibialis anterior and S1 gastrocnemius, and for S2 to S5, perineal musculature electrodes will be tagged. There is one more thing in EMG called triggered EMG. It is introduced for the evaluation of integrity of the lumbar pedicle screw, which is placed accurately in the pedicle. It is first described by Kalensi in 1992. The concept of triggered EMG is that the intact cortical bone should be electrically insulated for a well-placed pedicle screw from the adjacent nerve root. Here, the pedicle screw will be stimulated, and they look for the EMG activity for the particular muscle. If the pedicle screw is well placed, there won't be enough EMG will be produced. The integrity of pedicle screw placement should be assessed with directly stimulating the pedicle screw by stimulating by simultaneously recording the myogenic response from the appropriate myotomes. Using direct monopolar nerve stimulator, a series of incrementing level of current is given. Hello, sir.
Yes, Ravi.
So is my screen visible? There is a power.
It's not. It's not visible. You're not able to see your screen.
So just a second, sir. So now,
Yes.
okay, sir. Sorry, sir. Integrity of the pedicle screw. If there is a breach in the pedicle, when we stimulate, even with lesser volt, we'll get a EMG recording at the respective muscles. Okay, so even with when we consider there is a variation, when we have to be very cautious. That is called significant changes in monitoring modalities. Whereas in SSCP, when the amplitude reduces more than 50% and increases the when there is a latency is more than 10 milliseconds, then you have to be very cautious. When it's highly significant, when there's a complete loss of amplitude, we have to be very cautious. And in MEP, the threshold, as I said before, we always calculate the maximum volt which is required. Even with the maximum volt, we are not getting threshold. We have to increase more than 50 and 100 to get the required, the previously obtained waveform. That means it's significant. And where is highly significant is like complete loss of amplitude with even with 100 volt increase in the voltage. And pedicle screw triggered EMG, even when there is a EMG production at the respective myotome, even with lesser current, less than 7 millivolt, it is considered as very significant. The occurrence of definitive neurological deficit in the presence of unchanged SCP during intraoperatively, the possibility is 0.063%. And transcranial evoked MEP monitoring during spinal is safe and reliable method of monitoring corticospinal tract activity and is indispensable for high-risk surgeries. And there is no evidence that transcranial electrostimulation has resulted in development of epilepsy or brain damage. It has a risk of lip laceration, tongue laceration. Rarely a mandible fractures have been reported. It has a relative contraindication for transcranial electrostimulation, includes in patient with epilepsy, cortical lesion, and a skull defect, and increased intracranial pressure, and cardiac disease, and patient with cardiac pacemaker, and other implantable biomedical devices are contraindicated for this, relative contraindicated for this surgery. What we'll do when there is signal loss, what we have to do? That time, like whenever there's a loss of signal intraoperatively, it is a stressful situation for all. Sometimes it may be a technical error, maybe a false positive result alert. To prevent that, initially they followed an algorithm to know where is the error. First step, always check the equipment. And second, we have to always check for anesthetic change. Did they change any medication? And step 3, improve the perfusion. And step 4, reverse the manipulation and widen the decompression. And stage 4 is like going back to the age-old classical Stagnarov wake-up test. What is check the equipment? Important to ensure that the loss of signal is not because of equipment malfunction. Sometimes the electrode can be dislodged from the scalp or muscle. During manipulation and positioning the patient, the electrodes tends to dislodge. So we have to check for the electrodes which is placed properly. And after checking that, we always check for the electrode integrity, and next step check for the circuit discontinuity. Sometimes the wire may be disconnected from the machine. Finally, monitor the monitoring equipment and including stimulation device and recording boxes should be inspected because they may malfunction after exposing to irrigation and blood. Another source of signal distortion may be electrical interference from digital equipments like warming blanket, fluoroscopy unit, cautery machine, and large magnetic device tends to disrupt these signals. And assess the anesthetic changes. Like inhalation agents are known to alter SSCP and MEPs, and the muscle relaxant affects the MEP reading. So, total intravenous anesthesia is being proposed an alternative for inhalation agent because of potentially smaller effect on signal changes in SSCP and MEP. Usually, propofol, ketamine are preferred. And optimizing the cord perfusion environment. The next step for rolling out equipment failure and anesthetic changes is the optimization of spinal cord perfusion. SSCP amplitude decreases with ischemia and anoxia, causing the conduction block in affected axons. A minor drop in blood pressure can lead to significant SCP change, and the reverse with increased perfusion, also SSCP can change. To ensure the adequate cord perfusion, always maintain the mean arterial pressure at 80 to 90 mm of Hg. And if there is an anemia, when the Hb drops less than 8 mm, it should be reversed, and enough oxygen should be given to correct the anoxia. Stage 4, step 4 is like reversal of manipulation. The signal change frequently occurs after a mechanical manipulation of the spine. It is important to address, or if possible, reverse the offending step, last step. And we have to wait for at least 10 minutes after reversing the mechanical manipulation, last done mechanical manipulation, for the signals to return. Even with all the 4 steps, we are not getting the signals are not returning. So further decompression at the concerning level is needed to ensure that epidural hematoma formation or any remaining osseous compression is not responsible for the signal change. Even after doing all this, the signal is not coming up, means we have to consider Stegner's wake-up test, that is lighten the anesthesia and wake the patient up and ask to mobilize. Always we believe the potential benefit outweighs the risk. Like this previously this algorithm was followed, but this is time consuming and very anxious for the surgeons. So the new checklist have been introduced. In this, like surgeon, the technician, and anesthetist simultaneously, parallelly check for the things. In surgeon, what he has to do is stop the current manipulation and assess the field for any structural cord compression, any misplaced hardware or bone graft, or osteophytes or hematoma, or perform further decompression if stenosis is present. Consider reversing the correction of spinal deformity. At the same time, the neurophysiology should repeat the trial of MEP and SSCP to roll out a false positive alert and check all leads to make sure there is no pullout of electrode, or add additional electrode for the proximal muscle group if possible, and assess the pattern of changes, whether it is symmetrical or asymmetrical. If it is an asymmetrical change, maybe a cord or nerve injury is suspected. If there is symmetrical changes, both the lower limb or both upper limb presenting the same changes, means symmetrical change, maybe because of hypotension or anesthetic agent have been changed, and quantify the improvement and communicate to the surgical team. At the same time, surgeon anesthetist has to assess whether the neuromuscular blockade, the muscle relaxant given, is deep enough. Check via train of 4. It is like monitored via twitch monitor to know the depth of muscle relaxant given, and verify that no change of anesthetic admission occurred. And anesthetist should assess the depth of the anesthesia by monitoring BP, respiratory rate, heart rate, and BAS monitoring. BAS monitoring is bispectral index. It is an algorithm to assess the level of consciousness by analyzing the EEG reading. It compute from 0 to 100 and give a result of whether patient is how deep anesthetized, and restore and maintain the mean arterial pressure to 90 to 100, and check for intraoperative hemoglobin. It should be maintained more than 9, and if required, it should be corrected. And check for the temperature in the input-output for adequate resuscitation, and check for extremity position in case of plexopathy, and lighten the anesthesia. Even after all this, there is no change. Then increase the mean arterial pressure by 100, maintain it more than 100, and consider steroid administration, like given 30 mg per kg. And if all this, then go back to the classical wake-up test. If not, consider aborting surgery, or consider topical calcium channel blocker. All this helps to give a safe surgery for the patient. Thank you.
Ravi, this neural monitoring is predominantly used in the field of pediatric anesthesia, isn't it?
So not only
Hey, Ravi.
sir, even in pediatric also, sir, and also in deformity corrections and any spinal tumors mainly used, sir. And skull-based
Indications in our setup, in what all cases we use this?
So we used in the deformity corrections, scoliosis and deformity corrections.
Nowadays, it is mandatory to use this device for all the deformity corrections, or it's an optional one?
No, Shyam, it's not mandatory in India. There is nothing medico-legally we have to do with neural monitoring, but possibly in future it may become. For now, we use in all those cases where in which we are expecting a lot of deformity correction. Anything more than when we need to correct more than 20 to 30 degrees, we use neural monitoring. We are getting it from Chennai actually.
What is the cost incurred, sir, for this neural monitoring?
They actually take 25,000 plus GST. Comes to 29,000 something.
இந்த லோன் அமௌண்ட் 71,000 இருக்குது. என்ன இது இருக்கு? Loan amount.
Yuvraj sir, your mic is turned on. We are able to hear your loan.
Okay, sorry.
So, sir, does it mean that we have options of doing any neural monitoring related research for such cases, sir?
Research பண்ற அளவுக்கு we may not have இதுங்க. And as such but we are using it when required. It is actually very helpful in the sense like one of the cases which we use for high grade listhesis. This is some 2 years back. When doing the correction, there was a signal loss. So and we immediately reverted the correction and we waited for the thing. But still, the child woke up with the child is a young adult, like 20 years or something. He woke up with 3/5, but then he improved to 5/5 in a month's time. So it helps too. The last case in which we used, we had a spontaneous signal changes when we were actually taking off some soft tissue around the very stenotic area. That again recovered. But it alerts us not to go very aggressively or something in that area. So in all those cases where we are expecting a lot of deformity, anything more than 20 degree correction or something like that, or in a grade 3 or grade 4 listhesis, we are now counseling the patient for monitoring and we are getting it done.
Can this be implemented? Sorry, sir, continue. Can this be implemented in elbow cases where we do ulnar neurolysis or patients with ulnar nerve symptoms just to check the nerve functioning, etc.?
It may not be very useful in the sense of this is basically for when we are involving more of a spinal cord than only the peripheral nerves.
Okay.
In lower lumbar also we have to rely more on the SSEP, which is a somatosensory evoked potential thing, than the MEP thing. Now this is only 52% sensitive.
Shyam, the point about peripheral nerve problems, it is a chronic stretch and compression. Immediate study may not give you a kind of a significant reports, because in spine, when we do these electrophysiological studies, it is an acute inflammation or problem which gives a good result. I think Ravi covered it very well on this different aspects of the problems and applications, and especially he dealt with the disadvantages on that. And also supplemented with the Ramlingam on the practical applications. I mean, my generation came through a system by which we didn't have all the facilities, but there were certain dictums which we followed. as we went through the spine, this thing. Okay, take for example cervical. I remember decompressing at C3 down to C6, and it was a case of myelopathy, and my assistant dropped a small forceps right on the things, and I had the problem on this. But luckily the patient recovered. Already he had certain problem of myelopathy, so the patients did not have much of this thing. But anyhow, it should not have been done. Okay, take for example the lumbar. Okay, he mentioned about pedicular things. That is why we say perfecting the thing, because where the nerve root is, we don't know. Maybe the disc might have pushed it. The disc may be a calcified one, and it may be at the higher end. So it helps you a lot. And reduction of the thing, spondylolisthesis, especially L4-5, L5S1, spondyloptosis and reduction is going to cause a major issue. So the dictum is, when we do a decompression in a chronic soft tissue problems, we go to the normal and come down to the abnormal. This is point number one. Ravi, this you're going to have more surgeries you will be doing. So it is ideal to define the normal and get down when you have a thing. Because the other one is, I agree, the scoliosis. Recently, there was an article, I remember which, I don't remember which journal, the use of this and acute correction and increase the loss of motor functions and how they reversed it. But Ravi, the point is calculating that where to have this, because as a surgeon, you would like to cut costs, but not at the cost of the safety of the patient. This is something, this thing, that's your concluding remark of safety first is the most important thing, and make sure you plan it well and do as per the dictum. But somebody asked about it is mandatory. No, it's not mandatory. We do all the preventive precautions and document it well. And then when you have a legal problem, this thing, but it is good to have it as a this thing. Not every center will have. Now, as Ramalingam said, you can get it from outsource, who can bring it regularly, and you can use it. And it's a good talk, Ravi. I think you've covered well. Thanks.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
No,
If you
good,
don't
good,
have any questions,
good,
can
good
we?
topic, interest for everybody. Good selection, sir. Thanks, Java.
Thank you, sir.
Gopal, thanks for participating. Okay.
Thank you all. Thank you.
Thank you.
Got any